There are several similarities between what's required to care for the health of frontline public safety workers and warfighters in the military. We'll talk with a veteran who's using his lived experience caring for those on the battlefield to ensure that public safety workers are ready both physically and mentally. On this episode of the Psych, Health, and Safety USA podcast. From Flourish DX, this is the Psych, Health, and Safety USA podcast. Safety at work is more than freedom from physical injury. To be safe, you have to feel safe. Join us each week as we discuss psychologically healthy and safe work in the USA. Welcome to this week's episode of the Psych, Health, and Safety USA podcast. I'm your host, Dr. I. David Daniels, and I want to thank you for tuning in. Each week, we seek to increase awareness of the importance of psychological health and safety by learning from the lived experiences, research, and expertise of our guests, as well as advocating strategies to reduce harm and minimize vulnerability to psychosocial hazards in the American workplace. There are actually a lot of similarities between the challenges that are faced by the brave men and women that serve our country's military and those that serve what I call the domestic military, particularly those in fire rescue, police, EMS, and a number of our other public-facing services across this country. But there's a dissimilarity when we talk about how these hazards are addressed. Again, I have not served in the military, which is why when I have these conversations, I try to find people who actually have. But I have served in, again, that domestic military side and recognize that particularly state and local governments will send folks out, expose them to all kinds of things, but not necessarily have all the supports necessary for those folks to continue to do a good job or to do a good job without significant physical, mental, emotional, or social impact. So that's what we're going to talk about a little bit today. Those similarities and at least one voice that has started to realize those similarities and also started to realize, try to take some of the benefits of, again, serving our nation in the military, some of the things that have been learned there. How do we apply that to help people that are on the streets of cities, towns, counties across this country? How do we help them be physically and emotionally safe as well? So again, my guest today, and I'm going to let him introduce himself because that's just the way I do it here. Rather than telling people's story, I try to let them tell their story themselves. And it starts off with what it's kind of a standard question for me now, but so who's Russ Burnham?
Hey, thanks, Doc. So, yep, like you said, my name's Russ Burnham. I'm a retired Army physician assistant. I retired just a little over a year ago after 20 years of active federal service. I was an enlisted healthcare specialist, sometimes referred to as a combat medic, for 9 years prior to going to PA school. And then after going to PA school, I served in some of the most storied divisions, to include the 10th Mountain Division at Fort Drum, New York, where I deployed as the primary care provider and medical staff officer to the 1st Battalion, 32nd Infantry. And then I went to the flight surgeon course. So the Army sent me the flight surgeon course at Fort Rucker, Alabama, and then was assigned to the 1st Air Cavalry Brigade at Fort Hood, where I served for 4 years. And then I closed out my career as the senior medical advisor for the 3rd Security Forces Assistance Brigade. And in how you and I became connected, I think it'd be important to kind of let everybody know is when I made it to Fort Hood after completing the flight surgeon course, in the period of just meeting new people that live in the local area, I met a battalion chief at the Pflugerville Fire Department, which is just north of Austin in Travis County. And, we were talking about what I did in the Army, and he said, "Hey, could you do what you do in the Army for the fire service?" It was a really great question. And that started a path, it was about 8 years ago to interaction. And then, about a year and a half to 2 years of investigation, discovery, and research and communication. We said we'd give it a try. And so about 6 years ago, I founded a company called Frontline Mobile Health. And really what it was to provide occupational health services to the fire service, which has now grown to all of public safety to include law enforcement and EMS. And, I think that in previous conversations you and I'd had is that, we believe that the mind and the body are connected, and very much to psychosocial hazards. A lot of the behavioral health issues that public safety faces are manifestations of many things, how they're treated, the environments they work in. Certainly can relate that to my military experience. And so I think that it's just a unique blessing, really, to have. So it's nice when you could use what you did in the military out when you get out. It's always kind of nice. But my purview is changing more to that kind of organizational level, much like yourself, and trying to advise leaders and organizations on maybe new things they haven't thought about, that, actions, policy, programs all have an effect. And you might not see it, as my boss would tell me in the Army, every decision has a first order effect, and usually it has a second, third, and fourth order effect that's sometimes a lot harder to see, and you only see with time. Sometimes you can plan for those effects, but sometimes you can't, and you kind of know when you went sideways when those arise. So anyways, I'm fully retired now. I'm the CEO for Frontline and the team principal, and my goal and mission has really been to help public safety organizations get to retirement and drain the retirement system. I think that's the goal. So that's become kind of our life's work, and just very thankful and humbled by the invitation.
Yeah, absolutely. It's you make me think when you talk about the interest in setting people up to be able to drain the retirement system. Sadly, it's just the opposite.
Yeah.
As a matter of fact, I believe that there are folks out there who are counting on the system working as it does today, which is, let's take somebody who's really young, really energetic, let's put them out there, expose them to all kinds of things. They'll do a great job for us. We'll promise them a bunch of stuff for the rest of their life, but we know good and well they're not going to get it because of what we've exposed them to.
Yeah.
And I don't know that that's really even intentional. I don't think it's, but I think folks know, the actuaries out there know, these folks aren't going to last much long past here anyway. So let's just go for it. So,
yeah.
But so when you hear the term, the phrase, the set of words, psychological health and safety, what does that conjure for you when you hear that?
Yeah. So when I see psychological health, kind of, as I said, like, I think I've learned through seeing thousands of patients, both in the Army and out, that the mind is a very powerful system, right? If you ever heard David Foster Wallace's commencement speech at Kenyon University, he talked about how the mind is a wonderful servant, but a terrible master. And, if you look at how the majority of people that commit suicide with a firearm all end up shooting themselves in the head, not other places. And so, it's just kind of points to how powerful the psyche of the human body is. And so, if we're not protecting that, or if we're thinking that the body and the mind and the things the body experiences are not interpreted and have second and third order effects on our health and well-being. So to answer your question, I look at psychological health and safety as, that's also protecting the body, right? So what happens if you're a runner, and that's your kind of, in some ways I joke around with, very athletic patients of mine and be like, running is your Prozac, going to the gym is your antidepressant. I get it. And that's okay, right? So what happens when that person has an injury that now prevents them from doing that activity that they love? Why do your knees hurt? Why are you depressed? Why is your psychological health poor? And it's because we took away something, or something was taken away, even if for a short period of time, even only temporarily, it hurts. And so if you're already in poor psychological health and then have something taken away, the safety of that is very poor, right? Like, you're already in poor psychological health. Right. Your safety for dealing with life and having some resiliency is lower. So that's why it's so important, just from my perspective, that to take care of your body, if you're not taking care of the mind. And the mind of your workers, right? It expands to the hive thing. And being a leader is hard because you're not only responsible for your well-being, but the well-being of your, your teammates and the people above, and, really, especially the people you're responsible for below you. Like, it's more than just making sure they have food and billets and equipment, right? Like,
Right.
are you caring for them as a human being and as a person? And so, anyways, I know it's kind of a broad answer to your question, but I've seen it so many times where the psychological health of somebody has a physical manifestation,
Absolutely.
and
Yeah.
they,
And sadly, that's the time that we start paying attention to the psychological part, is when it starts to affect the physical part.
that's
And
right.
in some, not all, but in some cases, the physical manifestation could have been milder, could have been eliminated altogether had
That's,
we paid attention to what was going on in people's heads and how they were thinking and feeling.
that's right.
So, so tell me a little bit about how a guy ends up being. How do you gravitate towards this, interest in healthcare? Because this is both physical and mental health care that you're involved in. How did
Yeah.
how did you end up there?
Well, I think, I enlisted in the Army in August of 2001, August of 2001,
Wow.
in the delayed entry program. And I'd wanted to serve in the military for a long time, but I met my wife of 23 years now very early. We got married, and, we subsequently had our first daughter, who's now graduating from college. But I realized, I hadn't really thought it out. I wasn't one of those kids that knew was going to go to college and had a plan. And so, but I knew I always wanted to serve in the military. My wife really didn't see. She's like, well, why would you do that? Why would you go and protect other people? Why don't you stay here and protect us? Right. So she's come around. She's a great supporter, and just, we were young, and, it was all about us. And so she made me a deal. She's like, well, if you're going to go in the Army, you have to do something that, doesn't put you in a place to kill people. So at the time, the Army was revamping the way it did its combat medic training and saying, hey, we need to give soldiers some sort of civilian corollary to when they leave, right? We can't just think that every soldier that comes in going to be here for 20 years. And that's kind of looking at the outside in. The military does a really good job of pouring back into society by giving people skills and experiences and things like that. And so the Army said, we're going to make all medics have to graduate the EMTB program. It was the first time ever. So you had to complete, after basic training, you went to Fort Sam Houston, which was in San Antonio. And the first 8 weeks was just civilian EMT school, not far different from most fire academies, right? You got to pass EMT before they, spend more time, money, in educating you to do that job. And so I was the second class of people ever that had to pass the National Registry to do that. And so I ended up there because I really wanted to serve. My wife's like, you can't go drop artillery or bombs or shoot people intentionally, right? Like, try to not do that. And, so I did that and just sort of fell in love with it. It's kind of like it was a shoe that fit. I didn't really know that it was going to fit that well, but everything seemed to just make sense. And, I apologize about that. We a little video problems, but so anyways, yeah, it just made sense. It felt right. And so I continued on that. We can finish the military training portion of that. So the first 8 weeks, all civilian EMT, second 8 weeks is all kind of military medicine. Like, how do you apply that to a field environment where you've got some of your questions on the inventory are, what about when you have to work far away from people, right? And, in disparate areas, and, it's just like, whoa, yeah, that happens all the time in the Army. It's like, that's the job, working away from family, socially isolated. You have your team, right? Like, the Army never puts somebody alone on an island, but still a huge risk, right? So anyways, I completed that, went to Fort Lewis, Washington, your old stomping grounds in Tacoma, and met my first physician assistant. I never knew what that was until I made it to my first duty assignment. And a really good leader in my life was a gentleman from the Philippines, and he was my first squad leader and said, hey, I'm going to introduce you to the PA. And I said, what's a PA? And he introduced me to him, and, we struck up a friendship and a mentorship, and I just realized that he'd walked a path very similar to mine. And it was another way to continue helping people, but own more of the responsibility. And I think that I wanted that, and was like, hey, this is really interesting, and I can do more and maybe have greater influence if I get more education and become an officer. And so I spent the next, 7 years going through college and night school and online school to get my requirements to go to PA school. And then again, I knew what I wanted to do from a very early age. I didn't know what I wanted to do till I got to the Army, right? But then when I got that, the path became extremely clear. And it just grew over time. And I really enjoyed, as I became a more senior PA, I really enjoyed advising commanders and leaders about the health of their force, right? Which included their behavioral health. And there was huge suicide rates in the Army at the time. And so, I think I might have told you this before, but, in 2012, if you came to my office for knee pain, the Army made you, Sergeant Daniels, fill out the depression questionnaire and the PTSD questionnaire and the alcohol questionnaire, because it was such a sort of pandemic at that point in time. And that behavioral health was really just, psychological health was really just becoming more mainstream, that they pushed it down to our level at the primary care, primary provider level, and said, hey, you can't not be comfortable with this. You have to learn to talk about depression. You have to learn to talk about stress. You have to learn to talk about alcoholism, and then what programs are available and how do you help people. And so it was sort of just a natural evolution. I wish to tell you that I knew I just wanted to help people, and then that's kind of where it ended. And as you, much like in the fire service, I would assume, and I've never been in the fire service, but what I can see from the outside in is that, the further higher up in rank you get, the further from the fire you actually get.
That's right.
And so I think that's common to the most large organizations that have, direct action type objectives. And so, it really relies on a commander. When you're more further away, you really rely on your staff to give you good information, and your decisions as a fire chief are only as good as the information you're getting fed from trusted resources.
That's right. Yeah. And
so
and as I think it was Ronald Reagan says, but you have to trust and verify.
Right.
Even if you get who you think are the right people, that has to be verified, which means you going out there and, kind of being amongst them. Something that you said was really interesting. You said early 2010s, 10, 11, 12, there was a conversation going on in the military about the connection between the physical health of the folks and then, what's going on in their emotions. Are there any particular experiences that you've seen, that you've had yourself, or that you've seen with other people, that had they had more information, you think they'd handle that different? Is there an example that comes to mind that this person got exposed to this thing, something bad happens, and you go like, wow, we should have recognized that?
Yeah. So, I had an experience when I was a brand new lieutenant. One of my first patients, he came saying, hey, I'd like to be on Prozac. I'd like to be on an antidepressant. I'm not doing well. I knew through some meetings that there was some non-judicial punishment that had gone on for something he had done, whether it was a DUI or something like that. And he'd been promoted to a certain rank and had to be demoted because of that. And so I was seeing him kind of after that. And there you go. There's a good example. Something happens externally, psychological input.
Yes.
And so he came and I saw him, and there was really no reason why not to at the time. And, I was making sure that he was going to what we would call behavioral health. That was how they were called in the Army, the behavioral health clinics. So a lot of times there are psychologists, social workers, professional counselors who can't prescribe. So we would work together, as a team to say, okay, you're the prescribing provider, you're the therapist, what makes sense for this patient. And so I started him on that medication, made sure he was seeing. And then about 5 months later, unfortunately, he went to Cabela's, bought a shotgun, went to a local park and killed himself. And, as you pull that back, as we found is that, there were, he had a lot of father issues, come to find out later, is that, his father was so, disappointed in the incident that happened prior to him coming to see me, that he never, he just couldn't deal with that, because he'd written a kind of a suicide note kind of explaining that and really apologizing to his father. It was just one of those things he couldn't get over. But the sad part was that, that he did that on a Monday when we did the sort of postmortem. We went back and looked in his records, and he'd seen his psychiatrist on the Friday before and had gotten a refill of his medication and even picked it up.
Wow.
And it just kind of was my first interaction of a patient kind of committing suicide. And unfortunately, it wasn't the last, but it was one of those things where I was kind of scratching my head. I was like, man, well, he was in therapy, he was taking medication, seemed to be doing well because he was, getting his refills, all of those things. But really where I realized is I was like, was anybody outside of, was his leadership, right? He was looking for approval, not necessarily therapy. And a lot of times, a lot of soldiers come from broken families, right?
Yes.
And,
Yes.
and your leaders become your surrogate fathers and mothers, whether you like it or not, right? And so it was just an acknowledgement that there was more going on, right? There was more going on under the surface, and you always are like, man, what could I have done differently? I know I could have done something differently. But that was one of those kind of inflection points in my career where I said, okay, hey, look, you got to think about this differently. Like, people are probably struggling and they might not, but I need to be better at asking questions, right?
Right.
It's my responsibility to be astute to those things. And so I don't want to berate the point, but there's some other lesser examples where that experience fed into other things where I'd start to see people for low back pain or chest pain I couldn't explain. And then when you started to tease it back, you realize that they were in a toxic work environment, right? Or they call it unproductive leadership, I think is the way they coin it now in the Army. And the Army's totally revamped the way it selects senior leaders because they've acknowledged that this is a thing, right? Like, just because you're good on paper doesn't, a police chief once told me, just because you're a good patrol officer doesn't mean you're going to be a good supervisor.
That's right.
And there are some psychological traits that we need to look for people to have empathy and listening and can, sort of see when people are there. So I would see all sorts of physical ailments, and it would get to a point where they'd be in my office and I'd be like, hey, man, what's really going on? Like, I know your back hurts, I know your chest hurts, and I'm not berating. I'm not saying that that's not actually happening, but there's something else going on. And then you start to feel divorce and loss of a child, and holy smokes, like, it was, there's just a lot of stuff that goes on under the surface. And it was really became my responsibility to keep asking questions, to keep, and then say, hey, look, I don't think your chest pain is coming from your heart, right? I think it's coming from your head. Real, right? Like, I wouldn't say, like, it's not that you're not having it. It is real, right? But I can't fix it with medication. And, a cardioversion is not going to fix your problem, and a cardiology referral is not going to fix it. So we got to tease that back. And really, it was helping more people walk along the path and figure out what was really bothering them, more so than what the physical manifestation of the bother was. So many of those, I mean, too many to count. It just became, you could start to see it on their face. But again, I had to stumble and certainly missed opportunities previous of, what could I have done better? And it just sort of really just framed my whole how I provided care, was that you have to care for the person that just happens to have this ailment they're coming into see.
That's right. That's right. Yeah. You said something earlier that, again, I find myself when I'm having these conversations with folks, having to remember that we have another question or someplace else to go, because something you say goes like, but you mentioned that, folks come from what some might describe as broken families. And my description is they come from families that are just very different.
Yes.
And these families, there are things going on with people that to them have become routine and normal, but some of those things are also harmful to them. But they've been harmed so long in the same way. That's just what happens at our house. So, dad gets drunk and, we get beat up, or, mom yells at us or whatever, or, there's a belief in corporal punishment or not, or there's, parents who withhold their love and affection from their children as a way of, there's all these things going on. Yeah. But here's the reality is what I found is, as I've had more birthdays, there's not a perfect family out there anyway.
No.
And so it's good to see that the military has kind of figured out that people are going to come in all these different ways. I guess I'm curious when folks outside the military are going to figure that same thing out, because you have organizations who get started and they have they put the nice banner up and say, oh yeah, we want the best people, public or private, because sure. I don't think it's endemic to one or the other. We want to have the best people. So in the public sector, public safety space, it's often, oh, we're going to have a list and we're going to test the best people. We want the best people and blah, 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 blah. And then we bring them in and we assume that they're as perfect as we thought they were. And they're not, because none of us are.
No.
But we have these systems that assume, oh, everything's perfect. Well, no, it's not. And when the person starts to demonstrate that it's not perfect, instead of addressing, we go, well, we couldn't be wrong. So you're wrong. It's really, really good. Well, no, actually, it's actually pretty good. And try to convince people out of what they really feel. All that need thing, that's just you getting old. That's,
Yeah.
So I really, really enjoy what you were saying about taking these signs and symptoms, like we learn in EMT school, sign and symptom about what's going on with people, and starting to peel the onion back to find out what's really behind it. Because there are all kinds of things behind it, all kinds of things.
Well, and I think that where it's going is self-awareness, right? Like a lot of times they don't even know that's why they're coming in, right? They haven't made that connection yet. And when the light bulb goes on, right? When they're like, oh, they now figure out what the problem is and they can go through that. And you're very right about broken families. You're right. Like there are people who have a biological mother and father still living at home and they still have tons of issues, right? To your point. So I agree with you wholeheartedly that we all probably come from broken homes in the sense that we were just talking about it, right? Whether we have moms and dads at home or not. And as we become adults or more birthdays, it's really about like, hey, well, what sort of, internal self-awareness look can I do? Because that's really where probably the greatest amount of freedom is. Right. And being able to acknowledge those things, and more importantly, even being able to communicate them up and down the chain of command. Right. Mm-hmm. Like it's one thing and you and I are both have done this where we conduct assessments or surveys online to gather data so we can try to advise leaders. But, it's really the insight, right? Just collecting the data as a factoid, right? If you can make that data actionable for the individual or the organization, now it becomes an insight. And that is very valuable. And it happens at the micro and the macro level, and what we're both trying to do so very desperately, right? And where can we affect the greatest amount of change? For you and I, it's probably at the organizational level, right? Because there's not enough of us to, meet with, if, you and I were talking about fire departments in Georgia recently. If you have a department of 800 people, that's a lot of manpower to
that's right.
help self-awareness with 800 lives. Can you affect all 800 lives if you can get the self-awareness at the leadership level, right? If they can become self-aware that actions and policies and psychosocial hazards exist, then maybe they can fix them for the good of the populace,
Yeah, absolutely. Yeah. Yes. Yeah. So talk a little bit about, so again, this background in serving the country in the military and the parallels that you've seen. So you said you met this battalion chief from Pflugerville. And, there's, as I said before, we are often described in fire rescue services as the domestic military, but there's some both similarities and differences. So how has that helped you, having that military background, to be able to have these conversations with folks in the public sector?
Sure. So a lot of veterans of all the services in public safety, police and fire, EMS. So there's, I don't know what the statistics are, but it seems like at least 3 or 4 out of 10 served in some capacity. And that's just anecdotal basis on our patient population, but a lot, more so than most other places that I've gone. I go to the bank and it might be 1 out of 100 that served,
right.
So that helps, having a shared experience, right? We used to say, like, sharing in the suck in some ways. That does endear you to your teammates, right? Like that is something, if you had a shared experience, that does connect you, whether you like it or not, a good experience or bad experience. Right. So experiences kind of bind us. And I think that what's different is that a lot of times when we're seeing our patients now, if you just went to medical school and you never served, and not that they can't be fantastic doctors, and there are that have never served, right? But you get into this mindset that my job is I come in, I see you for 20 minutes and I get you out because I have a full empanelment today. And I don't really have time to consider what you really do as a job. The military, especially the flight surgeon school, is a great example. So, the Army said, hey, look, you know how to take care of soldiers on the ground, right? So you have a 30 soldier platoon. and one of your soldiers on patrol has a medical emergency, a seizure, a heart attack, a stroke, something like that. Well, that is really unfortunate. It's not catastrophic. Like in the risk assessments that we do in the military, it talks about, what's the probability of it happening? And then if it did happen, how much would it affect your mission, right? Going from low, moderate, high, or extreme. And, so what the Army said is that, hey, look, that's really unfortunate. We can probably deal with that on a 1 to 29 basis on the ground. We can probably deal with that. It wouldn't be catastrophic. It would be high risk still, but it wouldn't be catastrophic to the mission. Take that same input into an Apache helicopter where you've got 2 pilots, $33 million, ordnance tied to the whole thing, more inputs than I think are humanly possible. It's pretty amazing. We could talk about the physical hazards of flying a helicopter. It's just insane. And that's the wrong time to have a medical emergency. The Army said, hey, look, but a pilot having a stroke, a heart attack, a seizure, wrong time. It is extremely, again, the likelihood is low, but it now becomes catastrophic because now you've got to rely on one pilot to fly that aircraft. If you were in combat on it's just the wrong time, right? So they just said, hey, look, you have got to think about the way that you manage, talk, and treat patients differently when the risk becomes catastrophic if something happens. So it really taught us that, you would give, a soldier that has high blood pressure, that's an infantry soldier, you could give him a whole host of blood pressure medications, right? You can give a much smaller number. We still need to treat high blood pressure, right? Like, yes, you can be a pilot with high blood pressure and you can be a firefighter with high blood pressure, but what are those side effects that could potentially go wrong in air or in a structure fire? They don't teach you that at civilian medical school, right? They don't, it's a real jump. I mean, it's not uncommon sense, right? I know I'm not saying that right. It's not that it's not common sense. It's just that that's not the way you're trained in the civilian world, right? Hey, this is the disease. This is the treatment protocol. This is the disease. These are the signs. This is how you treat it. It says, hey, this is the disease. Now overlay that on top of their job. Right. Totally different set of treatment you have to go through.
Right.
We've heard from our patients, hey, look, you get it. You understand my job, even though we've never been a firefighter. And I don't think that's why you don't have to be having been in the military to do it, but you have to change your mindset to be like, hey, everything that we do, everything we recommend, everything we suggest or point or direct or leads a patient down a road to better health to drain the retirement system has to be framed in that they could be in the worst structure fire of their whole career tomorrow or as soon as they walk out of my office. Right. And so that's a wrong time to be having a medical issue, right? Like it's okay to have it like when you're at home or back at the station. We can it's still important and could be bad. It's just not going to be catastrophic, right? Like you and the whole team aren't in there.
So what you're describing from a purely occupational safety and health perspective is job hazard analysis to me. That's what that sounds like, because 100%. It's looking at the work that we expect people to perform and looking at their physical, emotional, and mental health in the context of what we've asked them to do.
Yeah.
Because there's these intersections where if you cross the bad thing happening and the job being done at the same time, it literally, as you said, it could be catastrophic, not only for them, but for a bunch of other people. Take this same mindset and apply it to a guy or gal driving a bus, a school bus, a train that's taking people from New York to DC on the, you pick it. Flying, an airline. There's all these things that we do that, and often our application of medicine, of health-related activities is almost so generic that it doesn't take into to consideration the environment that we've put people in, which matters. It matters a lot. It absolutely matters a lot. And I love the way that, that's being thought about, again, in our military. Like I said, it would be nice if some of that actually made its way out into the world that the rest of us are in. So what's, so again, you've been out doing this work with, I think you said that there are a handful of fire departments that you're working with and some other agencies you'll be working with. So just take the total population. What are some of the things that you've learned about the physical health of just this cast of characters to begin. Just how are they doing physically?
Yeah, so I think that age clearly is the greatest risk factor for all disease, and that is seen mirrored in public safety specifically, meaning the older the firefighter, the older the police officer, the more medical issues that kind of arise. Still high levels of cardiovascular disease and cancer, right? Suicide, I again, it is lower, but almost hurts more, right? Because, it's like they did it themselves as opposed to, hey, look, the heart attack came and got them, or cancer, they did their best to wear 2 sets of gear and decon, and, it's tough. But I would say that all 3 of those are there. We could really dive into the psychological one too, because I think that they start to have physical manifestations that are real. So, let's talk about sleep, right? So, little vignette here. I had a good buddy of mine who I was in PA school with, who was in the 4th Infantry Division as a medic in northern Iraq, and saw some pretty terrible things, right? And we became friends. He sort of related to those. And then he also related to how he had overcome that. He said when he got back from deployment and went to Fort Carson, he was really struggling, couldn't sleep, goes to the psychiatrist, and he said she was a little old lady, probably about 96 pounds, maybe 82. He said she was just this sweet little grandma. And he's this big guy, right? Like he's like 6'4", 265, just an animal, but a sweet soul, right? Just a gentle person and just a really good human being. But he knew to reach out at least, right? And he told him, she said, hey, the first thing we're going to do is we're going to get you to sleep. Like, we're not going to pass go. We're not going to do anything else. Like, we are going to get you some sleep. And that story has launched into a lot of stuff in public safety where, and even talking about how we reproduce hormones, do emotional consolidation, physical restoration, all of those things. And that, it was the environment, things that he saw, right? Like in all actuality, it wasn't nothing physical happened to him, right? It wasn't that he was reliving getting shot himself. It was what he saw in his environment, being away from his family, northern Iraq.
Right.
I mean, it just makes perfect sense to the stuff that you really are passionate about. And it came back, and I see this all the time in public safety. So this is why there's a corollary here, is that, sleep by far and away is the thing that people struggle with. Now, shift work doesn't help, right? This is the thing. We were on shift work while deployed, but when you're not deployed, you're not on shift work. So you can kind of level that out, where in public safety, whether you're on a 24/40 or 48/96 or working nights as a cop, your shift work screws with your rhythm. It does. We screw with your rhythm long enough, it affects you physically. So you see higher levels of hypertension, right? So high blood pressure, which is the #1 risk factor for stroke. Anxiety, here's a great psychosocial thing. So one of the last general officers I worked for, I had to have him on blood pressure medication. And he'd tell me, like, doc, when I go on leave for 2 weeks, my blood pressure goes normal. And I said, yeah, sir, like, I get it. Like, yeah, this is occupationally induced hypertension, but it is really high because your stress level is so high at work, the demands, the hours, the separation from all of these things. Like, so I told him, I said, until you retire, like, you need a therapeutic retirement. And he gets the choice to choose that, right? Like, I wasn't like, you need to retire. I was like, sir, this is just this is the row you're going to have to hoe until you decide to hang it up, because the psychosocial hazards are having but putting you at physical risk of stroking out, because it's tough. This is a tough job. Like, there is no doubt. And when I explained it to him like that, he's like, damn, you're right. Like, okay, I'll stop fighting taking the blood pressure medication. I was like, yeah, stop, just take it till you retire. And then my guess is you're not going to have to take it anymore. You know what I mean? Because he was just a physical specimen, right? Like, took really great care. I think that was one of the guys that I used to know that, like, if he wasn't in the gym for an hour a day, we're all like, whoa, did the boss go to the gym? The boss went to the gym, will be a good day. Right.
So I guess I have to wonder, and I'd love to get your perspective. And we kind of hinted at it earlier when we talked about this reality that the actuaries know that a lot of folks are not going to live healthy enough to collect most of these benefits we say we have out there for people.
Yeah.
But why, on the other hand, why is it that as a society, we aren't paying more attention to how people are feeling emotionally before we start paying attention to how they feel physically? It's like those signs we pass, don't worry about it, suck it up, deal with it, the job's tough, blah, blah, blah. And even as an employer, we put you in situations that are going to expose you to all kinds of emotional things, but then you got to deal with it on your own. I guess what's your thought about that?
Okay, it's great. It's a great topic. So this is very interesting generationally, right? Like you and I are separated probably by, 15, 20 years probably, but let's just call it you're one ahead of me, right?
Sure.
And I would say that, the leaders that I work with that are of your generation, or when I've met them, very few of them that I work with actually, because a lot of times they'll hear about what we do and they're like, well, what do I do if I get somebody that says they're being harassed at work? What do I have to do? Now I have to do something about that. And I don't want to know. Like I want to fingers in the ears. I don't want to know. I would tell you that as it's gone down, and I was watching football, probably this last weekend, and I saw as a Big 12 or Big 10 game. It doesn't matter, but it came on and it was where you had players and coaches from the specific league saying, hey, you know what? Like we encourage our players, like, if they're struggling mentally, to go talk to the counselor, right? Like if you were hurt your knee, you'd go see the trainer, right? So we try to encourage. So I feel like it's coming. It's just very slow. Your podcast didn't exist 20 years ago, right? The awareness of this is that, you, one of the reasons why I admire you so much is that you're one of those leaders that is like, no, like my ears are open. My ears are open and I am listening, right? My eyes are open and I see. I don't know why generationally that is. I have a fire chief that also told me, why we do such thorough new hire evaluation, psychological and medical, is he said there's a lot of, whenever we go to a new department and start working with them, there's always some friction between the older group and the younger group. The leaders can see it and they know, hey, look, we're just going to have to do this. And so what he says is, hey, look, we're going to just breed it out, meaning we're going to expose our young recruits, men, women, all different ethnicities, we're going to expose them that this is the level of care and the questions we ask at this department and that we do something about it. So that when they're my age, 43, or your age as a fire chief, it's just second nature. They've been asked about their psychological health and have opportunities to get care from the very beginning. It's so I think it's coming. It's interesting when I go in to talk to fire departments and I'll ask them, I say, well, what are the three biggest killers of firefighters? You'll get a mixed bag. Some will say, oh, well, heart attack. Well, if you ask FEMA, that's right. FEMA will tell you that, stress and overexertion are the number one killer. If you ask the firefighter cancer support network, I saw literature that says, oh, cancer outpaces line of duty deaths 3-1. Firefighter Behavioral Health Alliance says, well, suicide outpaces that 3-1. So I'm like, okay, well, they're all important, right? Like I've told you this before, I'm sort of agnostic as to which one is the most risky, right? They're all important and they all kind of weave together. And so I'll go in, and if they say suicide is the number one killer, like I go in this group and I say, well, what's the number one killer? Oh, suicide. Okay. Well, why is it that, you're the ones that also say, like, I don't want to fill out your assessment. I don't want you to ask me about suicide. Well, how are we supposed to address the number one killer of firefighters if you're unwilling to be honest? And then you get this, I've heard it before, you get the suspicion and conspiracy theories that chiefs just after their job. And after working 6 years now, close to 5,000 different police and firefighters across multiple states, I have yet to see somebody lose their job for being honest on a psychological health assessment. Not once. It would just totally ruin the whole process if it did.
Right.
Even the most suspicious people, nobody has, because I have yet to meet it. Well, first off, I don't think it's sort of recency bias. No fire chief or police chief would ask us to do services if they were just looking to headhunt people, right? And I probably wouldn't work with them. Be like, that's not what this is about. Like,
that's right.
So that might be why I've never had it, and I'm sure it exists. And I read the fire law blog and hear about discrimination cases all the time. Those are not in states that we or departments we work with. So I think it's changing, to your question, right? Like your podcast is one of those things, right? Like professionals like you who are in this industry saying, hey, look, this is a thing and we need to start doing something about it, right? Like, and it's not the way, it's just a way.
Yeah,
right?
That's right. Absolutely. Yeah. So when you were talking about this generalized fear that people have to participate in things for their own benefit, it goes back to the entire discussion about psychological safety within the organization, or the ability to be able to bring your whole self and be yourself without fear of retribution from the group.
Yep.
And it also brings up the importance of recognizing psychosocial hazards, which are psychosocial factors that are perceived or experienced by the person as negative or as a threat to them.
Yeah.
So
Really.
when people don't participate, they're not participating because of their perception. It's rarely reality, but it's perception and then reality to them. So the person says, I don't trust my supervisor. Why is that?
Yeah.
That's a psychosocial hazard that they've identified. There's a lack of trust there. So why don't we work on that? If somebody said that, I smell smoke, and we're both, somebody will do something about that, right? Well, that person is telling you emotionally, I smell smoke. There's something here, and what my body's doing, what my emotions are doing, they're trying to protect me by backing away and creating distance. But it's somehow folks don't think that we have to do anything about it until the person, does like they did in the fire department out on the West Coast, where the firefighter, goes into the fire station and shoots people, or sets their house on fire and invites. There's a story back in Memphis years ago where a firefighter who had exhibited significant mental health challenges for a period of time, and people laughed it off until he set his house on fire. Killed his wife, set his house on fire, and waited for the first arriving fire truck to show up to shoot them.
Yeah.
There are these signs and symptoms, and it's not as much of a secret. It's not as hidden as we think it is. We just have to pay attention to what's going on.
The self-awareness, right? Awareness in general, and then self-awareness within ourselves, right?
Absolutely.
I couldn't agree with you more. I would tell you that it is my assessment that, suicide is the culminating event of many, many hurts, right? Like it is. I have yet to hear a story, and I'm not saying that they don't exist, but rarely is it, I just experienced one thing and now I can't deal with it. It is a host of issues that date even in the case of my patient early on in my career. Really, it wasn't the Army it wasn't his experience in the Army. It was the disconnection from his father.
Right.
That was what drove him to be like, I can't live with this anymore. And that was a whole lifetime. The guy was in his late 20s, like it was, so to your point, it's not as subtle as we like to believe. Right. You're like, oh man, I totally didn't see Russ go in that direction. That just boggles the mind. Rarely it sounds like, dude, he was seeming a little off, and like, I have yet to have someone give me that testimony, like, dude, I totally didn't know. I didn't know he was struggling with anything, and I know they exist, but that is much rarer than the opposite, which is, there were signs and I just didn't do anything. I didn't mention it to anybody. And what's funny is that most people just, and I've been to, the Army even would put it to where we would have to go to, it didn't matter whether you were a provider or not. When I showed up to Fort Hood, everybody that was a sergeant or higher in rank had to go to a suicide first aid class. Couldn't even go to your unit until you completed 2 days of suicide awareness training, right? Because they felt that it was the leader's responsibility, that you need to be aware. And most of the thing was just talk to the person. Just be like, hey, is this, how are you doing? Just, literally, I think like reaching across the aisle to the person to try to show them a little bit of empathy, because, the social isolation of psychosocial risks, right? Like we have all these hazards, whether they're perceived or real, our experience, right? One of the first things people do is they start isolating.
Right.
If nobody's going to miss me while I'm gone.
Right.
Usually the signs to be like, oh yeah, Russ was usually this jovial guy. And then he just started to retract, and we just didn't, it didn't seem like he was the same. Yeah. Russ was socially isolating because he was struggling and didn't know he didn't have the words to process. And I think as human beings, we need each other to do that. Like I do. I don't think we can do that digitally. I think that requires it's contact sport, right?
Right. It is. So I want to ask you about how Frontline goes about, seeing and addressing these. But before we do that, I just want to tee that one up. But I was in a conversation with someone recently, with a group recently. And you hear, particularly again in the private sector, you hear, well, we don't really have time to invest in that. What's your message to those who say, well, we don't have time to deal with that?
Yeah. You don't have time not to deal with it. It's so counterproductive because those same people are to be the ones that, oh, well, people are our greatest assets. Yeah, those are probably the same people. I think, okay, that's great. You don't have time for. Help me understand what's the greatest asset to your company, right? Honestly, if they said anything, I mean, unless they were a software company and they just had one guy working, he's like, well, my computer is my most important asset, but then he's got no one to worry about but himself, right? But any organization where there's multiple human beings going, the thing doesn't work without your people. Like, it just doesn't. So if someone said my people aren't my single greatest asset, then there's a whole bunch of other issues right there, right? But so I don't know how people not do it, right? How do you not have time for it is my question. It's almost, there's no response. As like it's a rhetorical question. Like, how do you not have time to ask the tough questions? We could go down this, like, let me ask you a question. I think leadership development, we call it PME or professional military education, but a lot of professional military education is really just built around leadership. How do you lead troops into combat to be the sort of physical arm of the US government? How do you do that to maintain sanity, like protect your folks? So this was mandatory, right? Like, it didn't matter. As soon as you get promoted from E4, you're not even a sergeant yet. They're like, yeah, you have to go to primary leadership development school, right? Like, you got to go. You're not even promoted yet, but we're going to start training you. This is how you march troops around. This is how you talk to them. You get inspected, right? And then every single rank you go up, the military has these structures in place. And what I noticed in the fire service and in public safety in general is that you have a requirement that you have to go get. Like, I'm sure, you probably went to the National Fire Academy, but that was because, David Daniels wanted to, right? It wasn't because your chief was like, you have to go, you can't have this job until you do this. Like, we do this for everybody. I mean, it didn't matter, man, woman, race, color, like, it didn't matter. Like, when you were in the military, you hit that rank, we sent you. There was no, you had to have some heroic excuse to get out of it. That's how much they valued it. And they expose you to things like equal opportunity and how do you identify racism and how do you identify bias? Like, this is all, if you don't, but they make us go, which I believe is so powerful. The time when you're going through it, you're like, this is dumb and I'm doing it just to get promoted. But again, I didn't see it at the time, but just how important it was, because I just see a lack of that in the fire service. There's no requirement,
I see a lack of, because we have too many systems or too many places in these, in the country, too many organizations that are people dependent and not process dependent. What you just described is a process dependent system. It doesn't matter who you are. If you're going to do that thing, this is what you do first. That's right. Because we've determined to be successful at that, you need this set of skills. We don't make any assumptions. We don't even care whether you've had it before. You're going to do it this way.
That's right.
And again, while there's a part of me that recognizes, I believe you can still do that and be compassionate and kind and that type of thing. But it's still about, if you're going to expect one human to influence the behavior of another human, there's some things that leader needs to know. You can't, they just need to know it. And an organization should feel it's important enough that everybody gets it. It doesn't matter where you came from. Now again, if you come with a certain level of education, certification, qualification, what have you, that might help. But will it help here? Will it help here? And I think a lot of the failure from a safety perspective in general, both physical and psychological, a lot of it starts at the very beginning when we're not clear about what this environment is going to be. That's something I found in my research, is that the participants in my qualitative study, that the bell went off when I realized that the participants that had been prepared for the hazard they were going to be exposed to reacted to it in a more positive way.
Yeah.
Because I had a person tell me that, look, I faced all kinds of things, but my parents and the school that I went to, they told me that this was going to happen. So when it happened, I didn't even necessarily like it, but I knew it was coming. I was prepared. I was more resilient than folks. And I have to say, folks like me who were not told anything, were just kind of tossed into it. And it's all going to be, I was raised in a community was, oh yeah, we're all the same and we care about everybody. And not really.
Yeah,
Not really. That system
sure.
really wasn't made for me. And then you go in there and you get slapped in the face with reality. So I think a lot of it is simply being objectively clear to people about this is the environment. And I think we said this earlier. We cannot eliminate all psychosocial hazards. It is not possible. Stop the nonsense. You can't
Right.
eliminate. Part of the job is caring for other people, being by yourself, facing folks who might be hostile, having a bad day, that is a part of the job. So how do we help you in advance of that? How do we
That's
let you know that's going to occur? How do we help you be more resilient? How do we put resources around you when you need help? So, I think people sometimes get this mixed up that when I talk about, the organization needs to do a better job. I'm not saying that you have a magic wand and you can eliminate all that stuff. I'm not saying that at all. I'm saying that if you make the leadership decision to send people into battle,
That's right.
into a burning building, into an emotional confrontation with other people, that you should tell them that's going to happen in advance. Because if you don't know why, you send them in there
Yeah.
and prepare them so they can come out of it with the best possible outcome.
Well, if you, yeah, this is where kind of Eisenhower's, famous statement is that, uh, all your planning goes to pot as soon after the first the first shot is fired, right? But he said planning is indispensable. Your plan goes to crap as soon as the first shot is fired, but the planning is indispensable.
That's right.
Because to your point, right? Like this is the preparation for the things that could happen. You can't predict how they're always going to happen, but again, if you can at least know that a hazard exists, it's not so shocking when it smacks you in the face, right? You're like, okay, well, I didn't know when it was going to come, and it came, so I am better prepared.
Yes.
To handle it, right?
Yes.
Yeah.
So share a little bit about it in our closing. Share a little bit about how Frontline does that. I mean, how does that work out for you when you're working with organizations?
Yeah, so we do a lot of before we see anybody, we try to gather data from them in a private environment, so on their phones or whatever. Unfortunately, it's not scalable to do it on paper or in person, so this is the way we collect data in mass. Is you'll have a firefighter or a police officer fill out industry standard questionnaires on sleep, depression, anxiety, stress, social support, isolation, right? Those sorts of things, compassion, burnout. And then we ask questions about, you sort of start with that. So we've sort of psychologically, okay, I can probably connect if you ask me more about myself first. And the way that we ask it, like most people are less threatened if I ask you about your sleep, then I go straight to asking you, hey, are you depressed and thinking about killing yourself? Right. So there's a method to the madness, right? Like, can you make it approachable? Try to, again, reduce the stigma to say, hey, look, like these are just things, right? Like there's no judgment, but like if we can get them to buy in, so we have them take all of those, and then we dive into what about the health of the organization, right? So we asked you about your psychological health. Now let me ask you about your organizational health. What kind of trust and leadership do you have in this particular department, right? What's the culture of safety? Now we're talking about physical safety. It'd be nice to expand this out to psychological safety, right? But what do decision makers and immediate supervisors, how much do they value safety, and do they show that? Do they reward, acknowledge, train, make it a priority? What about unwanted workplace experience, right? That is one of the kind of psychosocial hazards, unwanted sexual, jokes. What is the prevalence of racism in your department organization, sexism, trying to establish romantic relationships when you don't want to. Those are all big hazards, right? So it kind of like, again, we talk about the individual, then we expand that out to ask about how are you, the individual, doing in this larger organization? And the big one is that even if these things are happening, what's the likelihood that you feel you can use your chain of command to address these concerns without fear of reprisal? That's kind of like my one question, that if I could say, hey, chief, like people are just people, right? Like this is going to happen. Like I wish we could get it and blot out racism and sexism. And like, that is my hope, right? But what my bigger hope is that if people are experiencing those things, real or perceived, is that they trust you enough to bring it to your attention. Because how can you fix it if you don't know? So that's kind of where we go. So we ask all those questions. Then, a week, 2 weeks later, we'll see them in clinic. Usually we either go to the fire department or police department, or they'll come to one of our offices. And we start checking their physical health, right? Like their vision and how good are you seeing, right? Sometimes, hey, David, you need glasses now. Do you know that, right? Like I need you to be able to do facial recognition in low light thing still, right? Like it's good. Like it's okay. You can still be on patrol. You can still drive the fire chief truck. I just need you to get some glasses, right? Hearing, I need you to be able to hear conversation, your subordinates, your peers, your superiors. You got to be able to hear at city council meetings, right? We put them on the most advanced cardiovascular testing known to the world, the gold standard cardiopulmonary exercise testing. We look them for cancer because that's a huge deal in both public safety. So we give them x-rays and ultrasounds, and then we finally meet them in the exam room. And it's really interesting. Again, there's some method to the madness. We decrease the ability. You first address the body, which is what they're used to. You go to a doctor's office. Well, I'm just here to talk about my knee or my back or my high blood pressure. So they can get with that. But after we talk about all those things, after we talk about your cardiovascular risk, we talk about your metabolic risk, your cancer risk, we then pull out all those responses you gave us 2 weeks ago. And we say, hey, how's David the person, right? Like this is David the machine, right? All the data we just went over, that's David the machine. But there's still a person upstairs that's driving this machine. Let's talk about that. And I can't scan the brain. An ultrasound's not going to penetrate the skull. An x-ray is not going to tell me how good your brain health, your psychological health is doing. The only way you can get that is by asking it questions, right? So we ask those questions, and now we feed that back to the patient, the firefighter, the cop. And we say, hey, look, like there's no judgment. Like this is what you said. I almost like turn around and say, this isn't for me. This is for you. This is just an objective reflection of where you were when you came, and let's talk about that. And you'd be shocked that some real gruff people that kind of putting on a real tough facade to begin with, but then once they see you care about their machine, then you ask them about the individual, and they're like, oh, okay, I get it. And some will even say, hey, I lied on all that stuff because I thought someone was going to come take my job, so I wasn't really honest, but I'd like to talk about it now with you. And so it doesn't even really matter what the scores were, right? Like it's just a vehicle to begin the conversation, which is what you and I are trying to do right now, is begin the conversation that, hey, your psychological health, which is impacted by many things you can control and things you can't control, right, is part of your overall wellness, right? It just is. And so if we can we believe that if you can launch cops and firefighters back into their organizations where they feel like someone cared about the machine that does the job, but also the person who is impacted by the job and all the other things around it, that we might actually get people to retirement on their own terms, right? And drain that retirement system. And so we start with psychological health, and then we close it out with psychological health, in all honesty, right? And there's method to the madness of how we've kind of designed all that, but we've just seen as we try to change the culture, right? Like, why isn't it that way? Well, this is just our little attempt to change it one firefighter, one cop at a time. Once you get into it, it's true, that chief was very wise. He said, we're going to breed this out. The truth of the matter is, once you get through 1 year of asking somebody about their psychological health and nobody loses their job, the next year comes around. Right. Even the old guys that have been around a long time are now like, okay, I get it, right? Like I get that this is really a benefit for me. And I do not want to be angry all the time. And yes, I have a temper, and it's not really conducive to my marriage. And so I'm willing to have that conversation. And so that's what we do. That's kind of, I know that's a broad scope, but you just think about it. If I could distill it down, is you can talk about the machine, that's great. But if you fail to talk about the person, right? The person running the machine, right? The housing of the soul, the machine's just the housing for the soul, right?
Absolutely.
Like, so we just want to find better ways. If I could scan your brain, doc, and be like, hey, this is your issues, let's address all those. I would love that. I don't think that day will ever come. I think that your free will and your experiences and stuff are just, in some ways, I hope it never does come to a scan, because then we would lose the human interaction. We just become even more complacent in isolating ourselves more and more and more. I think it would lead to more. So if you just go get a scan and never talk to a human being, I think that actually just lends to the psychosocial answer.
It does.
So.
It does. Russ, I actually could continue to have this conversation, but I don't want my podcast episodes to be so long that people tune me out. So, but thanks so much for sharing again, I'm enjoying finding people that have a balance of a lived experience and some research and some expertise. And in this case, you check all three.
Sure.
And I think that's just really important. And I'm glad to hear that you're taking this what I believe to be a kind of innovative approach to the total health of the folks in these organizations that you interact with. So if folks wanted to reach out to you directly, what's the best way to contact you if they wanted to get more information about what you do?
Yep, pretty easy. You can get me via email, russ@frontlinemobilehealth.com. I'm on LinkedIn. Our company has, Facebook and Instagram and all that stuff, but me personally, LinkedIn, or you can just shoot me an email, russ@frontlinemobilehealth.com. If you want to know more about our services, it's pretty easy. It's a little long, but simple, www.frontlinemobilehealth.com. And certainly willing to take anybody's questions or concerns, or if they have stuff that we should be thinking about, I want to know. We are always open to learning and making the program better, because it's really not about us, it's about our patients. This conversation alone has, again, reignited things that we could do better,
Right.
that we can do better within our own organization, and how do we do that better for the organizations we serve. So I am indebted to you. I really mean that. I'm honored to be here, and it just means a lot.
Thanks. Well, Russ, again, I appreciate your contributions to this great conversation of the last hour or so. And for those who follow us every week, it'll always be something challenging, always something that'll challenge the way people think and challenge the way people are looking at this entire concept of psychological health and safety, because there are no simple solutions to this very complex discussion. And we're just looking to have more conversation and find the ways that people are addressing this here or there. And again, I think you've given us a lot to think about. So for those of you who are following the podcast, look out for another great episode next week. And we're going to call it a day for this time, and look to see you on the next episode of the Psych Health and Safety USA podcast. Thanks very much. You've been listening to the Psych Health and Safety USA podcast. To stay up to date with the best content on workplace mental health in America, subscribe wherever you listen to podcasts, and join the Flourish DX community at www.flourishdx.com.